This is Elizabeth Martin
and S.Kanmanthreddy
from Seattle Children's Hospital, the University of Washington School of Medicine. Thank you for your interest. We are here to summarize key points from an educational review article on infection prevention in pediatric anesthesia practice. We would like to thank section editor Dr. Mark Thomas for the invitation to prepare these materials and acknowledge our co-collaborators, Dr. D.Zerr and Michael Kallile, also from Seattle Children's Hospital. Healthcare-associated infections are an important source of patient morbidity and mortality, and prevention has become a priority among patients, providers, institutions, and regulators. Healthcare-associated infections in pediatric patients are associated with prolonged hospital stay and increased mortality, cost the healthcare system billions of dollars annually, and have financial consequences for hospitals with pay-for-performance incentives. Moreover, infection rates are quality metrics for comparing institutions. Surgical patients have many risk factors for infection. Healthy patients undergoing routine surgery are exposed to surgical stress, temperature dysregulation, and violation of normal protective barriers. Others may have compromised immune status due to underlying disease, or as a result of immunosuppression, malignancy, or malnutrition. Risk factors such as patient characteristics, for example obesity, surgical technique, duration of surgery, and sterilization of instruments are beyond the control of the anesthesiologist. We will focus on issues that are under the control of the anesthesiologist, specifically bloodstream infections, recommendations for regional anesthesia procedures and invasive line placement, and the role of anesthesiologists in prevention of surgical site infections.
Liz, what role do anesthesiologists play in bloodstream infections?
Anesthesia providers have the unique challenge of managing the patient's dirty airway and concurrently placing intravenous lines and administering medications while maintaining aseptic technique. Several epidemiological studies have identified travel to the operating room under the care of an anesthesia provider as a risk factor for catheter-associated bloodstream infections. Hand hygiene. A 2004 cross-sectional survey of all physician groups identified anesthesiologists as the least compliant with recommended hand hygiene protocols. Identified barriers to hand hygiene for anesthesia providers include access to sinks and sanitizers, workload, workspace layout, and culture. A published video observation of anesthesia providers in the operating room demonstrated an average of 149 hand hygiene opportunities per hour, with a 2.9% hand hygiene compliance rate, and highest workspace bacterial contamination occurring during induction and emergence, a time when the anesthesiologist is managing the airway. The current hand hygiene standards established for non-operating room environments are not easily translated to the workflow of anesthesiologists. Workspace contamination. The human mouth is home to more than 500 different types of bacteria, including Staphylococcus and Streptococcus, which are also identified flora in healthcare-associated infections. Airway management adds to the potential for bacterial contamination. Limited systems exist to keep clean and contaminated materials separate within the anesthesia workspace, and data shows that anesthesia providers' gloved hands are a likely source of contamination. In both single and multi-center investigations, a link between anesthesia provider hand hygiene, workspace contamination, intravenous tubing contamination, and the subsequent development of infections has been established. These data demonstrate the importance of aseptic technique when accessing any type of vascular catheter, whether peripherally or centrally located.
What are the evidence-based recommendations?
Number 1, hand hygiene. Anesthesia providers must be educated about the importance of hand hygiene, and hand sanitizers should be placed in a standardized, accessible location in the anesthesia workspace. Anesthesia providers must become involved in examining and defining opportunities for hand hygiene specific to the workflow of anesthesiologists. Number 2, minimize contamination in the anesthesia workspace. Suggested strategies include the double glove technique, where contaminated outer gloves are immediately removed after airway management, minimizing number and location of intravenous access points, physical separation of clean medication spaces and a dirty space for immediate sequestration of contaminated airway supplies. Number 3, develop a standard protocol for operating room decontamination. Literature suggests that operating room decontamination is inconsistent and inadequate, which increases the risk of inter-case bacterial transmission. Posting standard protocols as a visual aid in a standard location in every operating room, and training staff to the standard is one strategy to optimize compliance. Number 4, minimize contamination of intravenous access points. Strategies to decrease bacterial contamination at intravenous access points include inline bacterial filters, hub disinfection devices, and administering all medications via a clean manifold in a physically separate location. Siri, what procedural recommendation exists for anesthesiologists?
Several well-designed studies have demonstrated lower rates of catheter colonization and line infection with chlorhexidine skin preparation over other solutions. Care should be taken with low birth weight neonates due to the risk of contact dermatitis or absorption of chlorhexidine through the immature skin. Insertion bundles for central line placement are the standard of care, including maximum barrier precautions, skin antisepsis, and sterile transparent dressings. Catheter-associated infection rates may be reduced by using antibiotic-impregnated catheters. For arterial line placement in children, radial dorsalis pedis and posterior tibial sites are preferred over femoral sites. Barrier precautions should be used for peripheral sites with the addition of full-body drapes for axillary or femoral sites. Use of a closed system, limiting line entries, and a 15-second scrub of diaphragm access points prior to entry are recommended. Infection related to regional anesthesia is thought to result primarily from pathogen penetration through the skin, although contamination of infused medications and infusion lines also plays an important role. Current guidelines recommend removal of jewelry, hand hygiene, use of barrier precautions, and target site skin antisepsis. Other preventative measures include minimizing catheter dressing changes and voluntary disconnections of catheter lines, as well as using aseptic technique when such actions are necessary. Studies support catheter disinfection and shortening by at least 20 millimeters in the event of accidental disconnection of epidural catheter tubing.
How could anesthesiologists help prevent surgical site infections?
Surgical site infections are infections related to an operative procedure that occurs at or near the surgical incision within 30 days of the procedure, or within 90 days if a prosthetic material is implanted at surgery. Temperature control and timely administration of antibiotics are important in preventing surgical site infections and are directly impacted by anesthesia providers. Temperature loss is more pronounced in pediatric patients than adults due to several factors, including lower fat content, thinner skin, and larger body surface area per kilogram. Maintaining normothermia in surgical patients is important because hypothermia leads to vasoconstriction, which decreases tissue oxygen tension, increasing the risk for development of infection. The best methods to keep patients warm include forced air blankets, warmed IV fluids, increasing room temperature in the operating room, and pre-warming. Prophylactic antibiotics reduce the risk of surgical site infection by decreasing the amount of bacteria at the surgical site. Current guidelines strongly support administering antibiotics within 120 minutes prior to incision. Administration should be closer to incision time, within 60 minutes, for antibiotics with short half-lives, such as cephalosporins. Redosing recommendations during the procedure are based on the duration of surgery and the half-life of the antibiotic, which may differ for neonates in some cases.
So, to summarize,
healthcare-associated infections are an important source of morbidity and mortality in pediatric patients. Anesthesiologists have a unique role in infection prevention. Hand hygiene and workspace decontamination decrease infection rates in surgical patients, and novel strategies to minimize contamination must be incorporated into anesthesia workflow. Standard protocols exist for insertion and handling of central lines, arterial lines, and regional catheters, and implementing bundled interventions may most effectively prevent infectious complications. Temperature control and timely administration of antibiotics contribute to the prevention of surgical site infection. Further study is needed to more clearly identify other potential risk factors, including tissue oxygen tension and hyperglycemia. Thank you for your interest and attention. This concludes our discussion of infection prevention in pediatric anesthesia practice. For a more in-depth review, Please read the full article in the Journal of Pediatric Anesthesia.